Welcome to today's webinar on the topic of Medicare Part D Open Enrollment, October 15th through December 7th, 2020, a Center for Medicare and Medicaid Services webinar. My name is Delina Mobley, and I am from Kaufman & Associates. I will be your moderator today. Before we start with the presentation, I would like to review the features of the webinar interface. You should all see the first slide of the PowerPoint presentation in the middle of the screen and a Q&A pod open to the bottom right of the screen. We will answer questions after the presentation, but you can enter a question at any time into the Q&A pod. For those connecting over the telephone, please hold your questions until the question and answer session. Please note that all phone lines have been muted, and if you need technical assistance during the webinar, please type the issue into the Q&A pod within the Adobe Connect platform, and our tech support staff will respond to you. If you have technical issues while dialed in and listening over the phone line, the operator will be available to assist you. Finally, please note that today's webinar is being recorded. I will now turn it over to Bonnie Hillsberg with the CMS Division of Tribal Affairs. Bonnie?
Thank you. Good afternoon and welcome to today's Medicare Part D webinar, sponsored by the Division of Tribal Affairs with the Centers for Medicaid and CHIP Services. I am Bonnie Hillsberg with the Centers for Medicare and Medicaid Services Division of Tribal Affairs, and joining me on today's call are my colleagues and subject matter experts, Ken Gardner for the Centers of Medicare and Medicaid Services and Lieutenant Amanda Haggard from the Indian Health Service. The purpose of today's webinar is to learn more information about Medicare Part D. This webinar will provide an overview of Medicare prescription drug coverage, Part D, highlight updates and changes for the open enrollment period, which begins October 15th and runs through December 7th. The webinar will specifically focus on what Medicare Part D plans cover, how the plans work with the Indian Health programs, and how to sign up. If you get prescription drugs through an Indian Health pharmacy, you pay nothing, and your coverage will not be interrupted. Getting Medicare does not affect your ability to get services through the Indian Health Service, Tribal Health, or Urban Indian Health programs. Once you enroll in Part D, your Indian Health program can bill the plan for your prescription drugs and use that money to expand services for your community. To obtain further information on Medicare Part D, visit https://www.medicare.gov/part-d/index.html. I'm going to repeat that again. https://www.medicare.gov/part-d/index.html. At this time, I would like to turn the call over to Lieutenant Amanda Haggard and Ken Gardner, who will walk us through today's presentation. We will first start with Lieutenant Haggard, who is a pharmacist with the Clinton Indian Health Center in Oklahoma since 2013. The health center is located about 70 miles west of Oklahoma City. Lieutenant Haggard?
Hi, good afternoon, everybody. Like Bonnie said, my name is Amanda Haggard, and I'm a pharmacist with the Clinton Indian Health Center in Oklahoma. On my daily routine, I assist in the pharmacy billing process and the whole point-of-sale system that we have, which is a vital component for our revenue generation within our facility. I want to start by saying thank you for inviting me here today to discuss this topic. It is so important but yet often overlooked. It's really important in these government programs, Medicaid and Medicare, and how they affect our facilities in ways that just go so far beyond what we can see on the surface. The reimbursement that we bring in can affect everything from adding providers to adding new and better medications to our formulary and everything else in between. The revenue is a major factor that makes such a difference in the health and well-being of our patients every day. At my site specifically, we've seen this in the last 5 years. With revenue alone, we have added chiropractors, we have added physical therapists, we have added massage therapy, we've even added CT and radiology, and that's all been a result of reimbursements from Medicare. So it's super important, like I said, often overlooked. Most of our patients and staff think, you know, I don't need this. I have the services of Indian Health, so why do I need to have insurance? So I'd like to bring attention to reasons why we do need it and why it is important. Super important to take an active role in it, in expanding it and improving the billing process within the facility. Even if we have patients that have enrolled in it, but we're not billing it properly, it's not doing us any good. So it's a huge process, and it can be overwhelming. I just encourage anybody who's not paying attention to this to just pick something small, whether it be just signing everybody up that comes through the door and getting it on their profile, or going straight to the pharmacy and saying, we've got to do something directly with pharmacy billing. Let's start here. Just start somewhere and move forward. Okay, so to begin today's presentation, I will just briefly mention the various topics that we'll be covering. We'll cover some of these topics with more detail than others. This will just give you an idea of what to expect. We'll begin with information pertaining to Medicare enrollment, followed by an overview of the Medicare Prescription Drug Coverage Program, which is known as Medicare Part D. We will also cover some of the requirements and issues surrounding automatic refill by mail programs. They're gaining popularity like crazy, and how those pertain to Medicare Part D. I'll provide some information about the coverage gap along with requirements for fraud, waste, and abuse training, and then we'll finish with the highlights of what's new in 2020 and a few other specific pharmacy items. Patients that are newly eligible for Medicare have an initial enrollment period, or IEP, that's during a 7-month period around their 65th birthday. So this will include the 3 months prior to their 65th birthday, the month of their birthday, and then the 3 months following their 65th birthday. If a patient enrolls during the initial enrollment period, there is no need for the credible coverage letter. However, if a patient chooses to wait and not enroll during the initial enrollment period, he or she will need a letter of credible coverage to be excluded from penalties. I've included a link to a copy of the coverage letter from the IHS website. It's the third link in the references at the bottom of the slide. This document can be personalized and given to our patient as proof of coverage to prevent any monetary penalties. Each year, there's an annual enrollment period that runs from October 15th through December 7th, so as you can see, we're approaching the end of that. This is also known as the fall open enrollment. During this time, it is important to compare the plans for our patients because many of them will have changed from year to year. A plan that was a $0 pay plan last year may have changed to a non-$0 pay plan this year. Benefit coordinators satisfy this role at our site as the main point of contact for qualifying patients and helping them determine what is best for them. Another consideration is with the Extra Help program through Social Security. If a patient is approved with this program, it can open the window for Medicare Part D enrollment outside of that general enrollment period. CMS, which stands for Centers for Medicare and Medicaid Services, offers prescription drug coverage to every single person that's 65 years or older. There are some exceptions to this age requirement for patients with disabilities or end-stage renal disease, but generally speaking, if a patient is 65 or older and is paid into Medicare, then they are eligible for a Medicare Part D plan. The plans are all run by insurance companies and are all approved by Medicare. These plans must go through fairly rigorous standards to be considered a Med D plan, and there are specific requirements that CMS expects these plans to follow. They are not all the same, and it can be a misconception to think that Med D is the same regardless of the plan. Plans can vary in premium costs, drug coverage, deductible, and even drug costs for the same drug across different plans. The patient must also live in the service area of the plan they wish to join. The next few slides are mostly here for your reference. If you have never looked through or reviewed the Medicare You handbook, I would highly recommend that you take the time to review it. Medicare You 2020 is the official U.S. government Medicare handbook and covers a broad range of information. It can help answer some of the most common questions that our patients may ask. This handbook is designed for all Medicare beneficiaries, not those that are just eligible for IHS, tribal, or urban facilities. I looked through it myself multiple times to find information, and it's very, very basic, very easy to understand. So I'd highly recommend just taking a cruise through that and seeing what you find. All Medicare beneficiaries are able to view the information that pertains specifically to the Indian Health Service. I just want to read an excerpt from page 82 of the document just for emphasis on how we should approach our patient population when we're signing them up for Medicare Part D. And this is a quote from there. If you get prescription drugs through an Indian health facility, you will continue to get drugs at no cost to you and your coverage won't be interrupted. Joining a Medicare drug plan may help your Indian health facility because the drug plan pays the Indian health facility the cost of your prescriptions. Talk to your local Indian Health Benefits Coordinator who can help you choose a plan that meets your needs and tell you how Medicare works with the Indian healthcare system. So as you can see, the Medicare You handbook suggests the benefits for both the patients and the facilities. It's there, and I like that it's in there for them to see. It is very beneficial to both patients as well as the facility. It's important for our patients to understand that how much more we can do for them with this income and the revenue coming in. In order to help control fraud, waste, and abuse and ensure that Medicare beneficiaries only receive new prescriptions and refills that are requested, Part D sponsors require their network, retail, and mail-order pharmacies to obtain patient consent to deliver a prescription, whether it be new or a refill, prior to each delivery. CMS believes that unintended waste and cost could be avoided if pharmacies confirmed with the patient that a refill or new prescription received directly from a physician should be delivered. Such confirmation is unnecessary when the beneficiary personally initiates the refill or new prescription request. So this policy does not affect retail refill reminder programs that require a patient to pick up the prescription and does not apply to long-term pharmacy dispensing deliveries. It just basically keeps me as a pharmacist from going through all of my patients and automatically refilling every medication and shipping it to the patients if they don't request it. Because in recent years, many of these facilities have implemented mail-out programs that increase the availability and access to care for our patients. Some of us, like myself, we use the VA's CMOP, Centralized Medication Pharmacy Program, that helps mail it out to our patients directly from there, from that VA pharmacy. So many sites are using a combination of the programs to mail them out, the automatic refill, in an attempt to improve patient care through increased medication compliance and just streamline the refill process. Many facilities do this automatic refill and get patients to sign up regularly to synchronize all your refills because nobody wants to go to the pharmacy or, get bottles one every day for 30 days. And this is a way to help get them all at one time. But unfortunately, it's led to fraud and waste, and it can easily be done if we don't stay on top of it. For example, a pharmacy automatically refills and mails out patients' prescriptions in order to collect the reimbursement each month, but the pharmacy is aware that the patient is not compliant or not taking their medications at all or has been in the hospital, so they've not needed them because the hospital has supplied them, but we keep sending them just to receive the reimbursement. So I know it's not something that we expect to happen and that we think anybody that we know would be doing this intentionally, but it is an example of how fraud can happen. So we have to make sure we speak to the patients every single month before we mail medications, see what it is they need and when they need it. Another example of possible waste of medications is that we inadvertently contribute to if we mail out as needed medication to patients. So things like topical creams or nasal allergy sprays that you only need during a specific time of year, if we just keep mailing it every month to collect the reimbursement, we are wasting money. So, like again, we call them to prevent that waste. And that also keeps our money where it needs to be and where it can be spent on things to grow our patient care within the facility. So for this reason, CMS requires that pharmacies contact a patient prior to automatically filling and mailing any newer prescription refills in order to determine if a patient truly needs them. This must be completed prior to each automatic refill, whether it's new or refill. It, again, doesn't apply to situations where the patient calls or comes in and initiates it themselves. Not only must the consent be obtained from the patient each time, but it's very important that it's documented each time. So at the facility where I'm at, the pharmacist that processes all prescriptions each month calls the patient once they receive them, get a hold of the patient. They give about a week's notice, call them. That way we have an opportunity to call them again in 3 days, call them again in another 3 days, and document it in the chart. We spoke to so-and-so. They said they needed X, Y, and Z medication mailed this month. That way, should we get audited, it shows that we're actually speaking to these patients and only mailing the medications that they've asked for us to send. So the ultimate takeaway from this section, I know it's been lengthy, that patients enrolled in Medicare Part D must provide consent prior to each and every automatic refill. Documentation of this information will satisfy the requirements for the refill programs should we be audited. Okay, the coverage gap. Often you'll hear patients refer to this as the donut hole. It's slowly closing, and they say by 2020 it should be completely closed. The main thing about the coverage gap that we can help our patients get out of the coverage gap faster. Most of the time you'll hear people talk about the donut hole or the coverage gap because they're out at a retail pharmacy and they've hit into this gap, and so there's a large copay for their prescriptions. Like Bonnie said in the very beginning of this, at IHS, they don't have a cost for their prescriptions. But yet if we still bill insurance, it helps them get out of that gap faster. So it's helps them that should they need something on the outside at some point to go get a prescription, we've already helped them get out of that donut hole, or the gap as it's called, so that they don't have to experience that. Another point to consider related to our dual eligible patients, these are our patients that qualify for full low-income subsidy. They are not affected by the coverage gap, and they qualify for no-cost Medicare Part D coverage. From my experience, we will see patients that are enrolled in Medicaid that are qualified for Medicare. The pharmacy staff members working on point-of-sale claims will see a rejection from Medicaid that states that a patient is a QMB, or qualified Medicare beneficiary. This highlights the importance of communication between the staff and our facilities. The pharmacy staff member that sees this rejection should communicate with the benefits coordinator, who can then meet with the patient and get him or her enrolled in a Medicare Part D plan. This is tremendously helpful for these patients to be enrolled in Medicare Part D due to very limited and restricted formularies in our facilities, so we don't have all the drugs out there, so they may need to go outside for some prescriptions, and we want to make sure that they can obtain those. Many of our patients receive medications outside, whether it be because of location, it's easier to go locally than it is to come here, or our formulary, we just don't have them. So we do our very, very best to provide as many medications as possible, but we just can't provide as many medications as a retail pharmacy can. So these patients can sign up for a 100% low-income subsidy plan and receive medications from both our facilities and outside pharmacies. The hardest part about this entire process is identifying the patients that fall into this category. Again, this highlights just how important it is that we are communicating adequately among departments within our facilities. Regular communication between the pharmacy billing staff, the business office, patient registration, benefit coordinator, it's all a vital component to a successful strategy in increasing facility revenue. When the Medicare Modernization Act passed in 2003, it included a requirement for all Part D plans to have in place a program to control fraud, waste, and abuse. CMS further defined that requirement to state that all plans must incorporate fraud, waste, and abuse guidelines into their compliance plans and ensure that all of their contracted entities, including pharmacies, have policies and training in place to detect, correct, and prevent the fraud, waste, and abuse. The overall purpose behind the requirement is to protect the federal government and Medicare beneficiaries from fraudulent, abusive, and wasteful schemes throughout the delivery of a prescription drug benefit by ensuring plan sponsors in downstream entities, such as pharmacies, have received training to detect, correct, and prevent fraud, waste, and abuse. The fraud, waste, and abuse training requirement is an annual requirement and must be completed by all staff members that are involved in enrolling members and or billing for Medicare Part D claims. It is required to be completed by December 31st of each year, so many of you may have already received information on that. CMS offers a fraud, waste, and abuse training that is available through the Medicare Learning Network. There are 2 training sessions that must be completed. I have provided the link on the slide. Users will be required to create an account in order to access the Medicare Learning Network website. Once logged in, the user will see a link on the right side of the page. This is called Fraud and Abuse. When the user clicks on this link, a new page will open with several trainings available. The 2 that must be completed are Medicare Fraud and Abuse, Prevention, Detection, and Reporting, as well as the Combating Medicare Part C and D Fraud, Waste, and Abuse. The Medicare Learning Network will track your trainings and provide a printable certificate to keep for documentation purposes. When you are audited, and we will all be audited at some point, it's just inevitable, the auditor will ask for proof of fraud, waste, and abuse training. There are numerous resources available to offer this training, but I believe it's probably best to use the training option provided by CMS in order to prevent any confusion that may arise as to whether or not the proper training was completed. Because pharmacists, technicians, billing office personnel, benefits coordinators, etc., all help enroll or bill Medicare, these personnel must complete the annual training. If you're in doubt as to whether or not you need the training, the safest option would be just go ahead and complete it. It may be more pertinent to require all employees at the facility to complete this training annually to prevent any confusion, and then it would leave no room for error. This is just an example of the certificate that users will receive from completion of one of the trainings. What's new for 2020? So it looks like there's been a few changes, but not a whole terrible amount. In 2020, there are 948 standalone plans available across the country for Medicare Part D coverage. So this is an increase of 47 plans from last year. Each region has an average of 28 plans. And of those 948 plans, there's 133 plans that are available that have $0 deductibles. There are 313 plans available that have a premium of less than $25 a month. And the average deductible for most plans in 2020 is $435. Again, like we talked about earlier, using IHS when you have Medicare Part D will help you reach that deductible because we will be billing even though you were not paying anything here for your care. Discounts while on the donut hole for plans in 2020 will be within 75% on brand name and generic drugs. When this started in 2011, it was only 7%, and then it just increases, and it's up to 75% in 2020, which is effectively closing that gap or that donut hole that we referred to. Here are a few topics specific to pharmacy that will need to be addressed. There are more and more high-cost and/or specialty medications that are needed by our patients. These medications can sometimes be difficult to provide due to the cost constraints. Some examples include hepatitis C medications, which cost on average of $18,000 to $20,000 per month per patient. Without any pharmacy insurance, these medications quickly drain the entire year's pharmacy budget. This highlights the importance of trying to obtain coverage for as many of our patients as possible. It would be terrible to have to watch a patient's health deteriorate when we could have helped, prevent it with a medication like this if we were able to obtain it financially. Other disease states that utilize specialty medications are rheumatoid arthritis, severe osteoporosis, there's blood diseases. It's certainly not an all-inclusive list, but there are often diseases we face that have specialty medications. Sometimes the insurer will want to force a patient to use a specialty pharmacy of their choice. We have mixed success with getting around the requirement from these insurances. Some of them will say, make an exception for IHS and we can take care of it. Some of them won't. The next topic of significance is the maintenance of the pharmacy drug file, which if you don't work in the pharmacy probably means nothing to you. Basically keeping our drug files accurate so that when we bill something to insurance, to Medicare, we're telling them we're dispensing a specific drug, and that goes right down to the manufacturer and the brand. And we need to make sure our files are correct and that what we tell them we're dispensing is what we are dispensing, because that affects reimbursement. We want to make sure we're getting paid for what we're actually giving out. It's also a safety aspect so that if there are drug recalls, I know exactly which of my patients got which medications. Without the accurate NDC is what it's called, which is your code for that drug, without it listed, it's almost impossible to identify patients that received a specific medication. So pop in with your pharmacy staff, visit with them. If you have any questions, make sure these things are being done. I'm sure in most places they are by now, but here specifically, it went unnoticed for a long time. And then once we got the ball rolling and started checking things, it's just there's always something else that we can do to improve. Another issue that's recently come up is related to accurate quantity and days supply when entering and dispensing a prescription. So this not only pertains to ensuring the calculation of a day's supply, which is how long that medication is going to last you, based on the directions that the provider ordered, but it also affects us if the prescription is dispensed for a day supply greater than what the insurance allows. So if the pharmacy dispenses a patient a 90-day of supply medication, but insurance rejects it because they only say they'll cover 30 days, the pharmacy cannot rebill the claim and just say, oh, we only gave them 30 days even though we gave them 90. It's prohibited. It had been done in the past, and we've just learned recently that's something we've got to do better at, and we just can't do anymore. So I think I've got one more slide with a few resources. I think they may be beneficial to you. Ken's going to go I would ignore the first one. He's going to go quite a bit into detail over the Plan Finder. He will be the expert on that. So that is all that I have, and I'll turn it back over to Bonnie, and then we'll do questions at the end.
Thank you, Lieutenant Amanda. You did a great presentation, and you shared a lot of important information. So now we will turn the call over to Ken Gardner, who is the Program Training Specialist for the CMS Division of Training and previously spent 8 years with CMS as a health plan manager and outreach specialist at the San Francisco Regional Office. He has many years of operational experience with Medicare Advantage and prescription drug plans. Ken?
Thank you, Bonnie. So, if you have Medicare and you're looking to choose a drug plan, the question is, how do you find the best drug plan for you? And the way you do that is by using the Medicare Plan Finder. Medicare Plan Finder has just been completely redone. It is completely new for 2020. So we're going to talk about that today, and I'm going to give you just a little bit of demonstration of how that works. Sorry, having trouble advancing the slide. There we go. So this is the landing page for the new Medicare Plan Finder. You get here by going to Medicare.gov and click on the button for Finding 2020 Health Plan Information. So with the new Medicare Plan Finder, a new feature is that we want to strongly encourage people to create an account and log in, because it's better security, and also we can give the best, most personalized experience. And you'll see a little bit more about that in just a few minutes. If you already have a MyMedicare.gov account, then you can use the same username and password to log in, or you can quickly create an account. Down at the bottom of this page, there are two buttons. One is for people that qualify for a special enrollment period who are seeking to change their 2019 coverage, and that's probably not going to be a very, very big population. And the other is for people that are new to Medicare who want to learn more about what their coverage options are. For our purposes today, we're going to talk about a gentleman named Stephen, and he is a fictitious member with Medicare who wants to find out about his Medicare coverage options. I've added a yellow arrow here to show the buttons that Stephen would select to continue without logging in if he wanted to do that. You can think of this like when you're on a shopping website like Amazon or something like that as a guest instead of signing in to create an account. It works, but whenever you want to do something, if you want to buy something, you have to provide all of your information every single time, instead of the site picking up the information that's stored from your last visit or your last purchase, like maybe your address. But you'll get a better experience by creating an account and logging into the Plan Finder. If you or the client that you're working with is already created a MyMedicare account, the same username and password will work for the Plan Finder. Otherwise, you need to create an account, which is quick and easy, and you start by clicking on this Login or Create Account button. So if you already have an account, you log in here, or you can go down to where I'm showing you this yellow arrow to select the Create an Account button. And creating an account has been made much easier than it was in the past. If you ever worked with Medicare.gov, it takes 2 steps instead of the 4 steps it used to take. Since we're using screenshots, it may look a little bit like more than that, but it's really only just 2. So first you enter the Medicare number, and you don't need to enter the dashes, the last name, and the email address. Now that's optional. If you don't have an email address, you can just click the box saying that you don't have an email address. And just to emphasize, because a lot of people have asked about this, having an email address is purely optional, but if you put that there, you can get updates from Medicare, that sort of thing. We never sell lists. Scrolling down just a bit on that same page, you enter your date of birth and your zip code or the city where you live and the effective date for Part A from your Medicare card. Now, if that sounds familiar, that's all the same information that you used to use on the Medicare Plan Finder, except you have the option of adding that email address. Then you just click on the Continue button. And there you can choose a username. The username must be unique to that person. So something like an email address, if you have one, is a good candidate, or maybe a name and a zip code. So whatever you choose that will be unique to that particular individual. So you also pick a secret question from a list of options, and you add the answer to your question. And then you choose a password. That's really all there is to it. So our particular person with Medicare, Stephen Smith, creates a username and wants to use his mother's name, which is Doe, as the secret answer. He then adds a password and selects Continue. He's taken back to the login page, and there are information banners at the top showing that he's successfully created his account and explains he'll get a confirmation letter in the mail in 10 to 14 days. That's just a security measure, letting him know that an account has been created in his name. But he does not have to wait for that letter. He can log in right away. So he was created. And now he sees his current coverage information. Stephen is currently enrolled in a Medicare Advantage plan called Medicare You Advantage Complete. Now remember, this is fictitious information for educational purposes. Medicare Advantage plans aren't a good idea for most tribal members, but I created this presentation from an example that I had access to, so just ignore Medicare Advantage enrollment for now. So Stephen's decided to see what drug plan options are available for him in 2020. He checks the box to confirm, and then he needs to add a zip code. The plan finder needs to know the zip code where Stephen lives in order to show the plan options that are available in his area. Stephen is a member of the Navajo Nation and lives in the Window Rock, Arizona area, which is in Apache County, Arizona. Now, we found some people have gotten confused when entering the zip code, so to be very specific, here's what you do. First, you enter the zip code, and then you get a drop-down which will show the county for that zip code. Some zip codes cover multiple counties. If so, you click the county you actually live in. And then you click Continue. And then a Next button appears at the bottom of the page, and you click on that. So the next screen asks about whether he'd like to compare drug costs. He's checked the box saying that he does, because really that's the heart of what we're trying to do here, is find a drug plan that's best for him based on his medications and where he lives. So a box opens telling him to get ready to enter his drug list, and the next question is about whether he uses a retail or mail order pharmacy. For tribal members who wish to fill their prescriptions at a tribal or IHS facility, they should choose the retail pharmacy button. The mail order pharmacy is not an ICU facility, so just ignore that. Now this screen shows the personalized power of the My Medicare Claims database. Stephen gets a list of all the prescription drugs that he has filled through Medicare in the last year. He just has to check the boxes next to the ones that he still takes, because some of those he doesn't take anymore. This level of personalization is only available to users who log into the Plan Finder with their My Medicare username and password. And let me just say that if someone is new to Medicare, they won't see this list because they haven't filled any prescriptions through Medicare in the last year. So Stephen still takes omeprazole and prednisone and selects each of those, and the others are drugs that he doesn't take anymore. Alternatively, he could have checked the box at the top to move all the medications to his drug list if he wanted to go about it that way. And so now he sees his drug list, and here it shows the quantity he takes each month, or it could be 30 for each month or 90 every 3 months, however the prescription is written. And he gets a screen confirming that these drugs have been added to his list for pricing 2020 drug plans. He can still edit this list if he wants to make a change. And he has some new prescriptions that he wants to add to his list. And so we're going to click on the Add Another Drug button to do that. So this is the screen he'll use to start adding medications to his list. Note that there's a button that you can click if you had a saved list on the legacy Plan Finder, the old Plan Finder, if you will, and want to access that old list. So let's just take a quick look at that. If you used the Plan Finder last year and saved a drug list there, you'll have a drug list ID and password date. And you can enter that here to retrieve that old saved drug list if you want. Now, these legacy lists will only be available until the end of this open enrollment on December 7th, and can only be viewed or printed. They will not load automatically into the new Plan Finder. If there are drugs there that aren't in your list, you'd have to enter the drugs in the system manually. Now, of course, if you filled any of these prescriptions in the last year, then they should be on the claims list already, the one we saw just a few slides back. So you probably don't really need this list, but a lot of people really wanted to have access, so we made this available temporarily. But for now, let's just continue adding drugs to Stephen's list. So this is the drug entry page. When Stephen starts typing in the box, he'll get suggested drug name. In this case, Stephen is a diabetic and takes insulin. He takes the brand Humulin. So once he types in HUM, it appears on the list. He can select that from the list once he sees it. And when he selects Humulin from the drop-down list, the Add Drug button appears, so he'll click on that to continue. In most cases, when adding a new drug, the most common dose and quantity is pre-populated. But you can always change it. Also, injectable drugs have a packaging field, so he adds a dosage, packaging, and quantity, and then selects Add to my drug list. So now the system shows his drug list again. He's got 3 drugs now. He can add more drugs or say he's done adding drugs. He takes one more prescription, so let's add that, just to show you another feature here. So he starts to add Lipitor and chooses it from the list and then selects Add Drug. At this point, the system generates a pop-up showing that there's a generic alternative and pointing out that it's a lower-cost alternative to Lipitor, and asks him if he'd like to add the generic or add brand instead. So Stephen, in this case, chose the generic atorvastatin and can now confirm his dosage and add that to his drug list. So he sees his drug list once again. You see it every time you add a new drug. Now there's a total of 4 drugs on his list. That completes it, so he's going to select Done. Now that Stephen's drug list is complete, he's prompted to choose some pharmacies near him for the drug pricing engine to use. You can pick 3 retail pharmacies to price, which, by the way, is an improvement. The previous plan finder could only price 2 pharmacies at a time. So for our purposes today, what we really want to locate is Medicare drug plans that are contracted with the ITU that medications without cost. But the ITU pharmacy can bill Medicare and get additional revenue to provide those extra benefits to tribal members. So we're going to pick the pharmacies at 3 IHS facilities in his area. Scrolling down, the 3 facilities close to Stephen's zip code were Fort Defiance, Tohatchi, and Gallup Indian Medical Center. So we've picked each of those, and I had to crop this image a bit, but the blue line down at the bottom shows the 3 pharmacies that were selected, and there's a done button down on the right. So after you select pharmacies and click done, you'll be taken to the list of available drug plans for next year. Note that if the beneficiary, if Stephen was enrolled in a plan last year, then it is in the prior year, this year, 2019, it always shows first what his current plan is so he can compare. In our example, Stephen was enrolled in a Medicare Advantage plan, which again, most of the time is not a good option for tribal members. So we're going to look at the drug.
Thank you for your patience. Apparently, we're having some technical difficulties. Please continue to hold. Thank you.
Hi, so this is Ken Gardner. My call dropped, and I'm back on the line. Bonnie, can everyone hear me now?
We can hear you.
Great. So I apologize for that. So in this case, for Stephen, we have 31 drug plans available, and I'm not quite sure where it drops. I'm just going to pick up back a little bit. So when you reach the list of plans available, you only see in the first, what we call the plan card, this little box showing the plan information, the plan where that Medicare person with Medicare is currently enrolled. So in this case, it's a Medicare Advantage plan, and again, Medicare Advantage plans are rarely a good option for tribal members. So just ignore that. But we're going to look at the drug plan options, which will show below that where we just scroll down the page. The default sort that you first see is the lowest monthly premium. What you really want to do is sort by the lowest total drug cost, that is the cost plus premium. So we're going to change that in the area with this yellow arrow here. So once we do that, or once we click that, you can see this lowest drug plus premium cost, and that's the one you want. So you pick that from the drop-down menu, and the list will be sorted in that way. Now, why do we do this? Because the plan with the lowest premium may not include the drugs or the pharmacies that you've chosen, and so the cost can be very, very high. If the drug isn't covered by the pharmacy or by that particular insurance plan, or your pharmacy isn't covered, then you're not going to get any discount. And so you can see the cost here by the red arrow is $14,086.32 per year. That's because this lowest premium drug plan is a very poor choice for seniors. And we're going to see what we can do by sorting that list by the lowest cost. So now the list is sorted, and you can see that the drug plan with the lowest total cost, when you consider premiums and overall drug costs, is this particular Cigna Health Spring plan. Now this premium is quite a bit higher at $60.30 a month, but the drug costs are $1,468 a year, or about 10% of the cost of that lowest premium plan you saw before. Now, the next one down at $31.70 has a lower premium, and if student has Medicaid or extra help, the premium subsidy that he would get would reduce that premium to zero. That subsidy varies state by state, but it averages about $32 or $33 a month. And also, if he has Medicaid or that full LIS, it is zero deductible and zero coverage deductible. But our example is for someone who does not have Medicaid or extra help. So maybe he pays the premium himself, maybe the tribe pays the premium, whatever the choice. So his lowest cost overall would be the Cigna plan, and that result can vary for every person depending on the medications they take and the pharmacies they use. You can just click on the View Drugs and Pharmacies where I've added the green arrow to see the details of how drugs are covered at each pharmacy we selected the price. So when you click on that link, you get to a page that has detailed coverage information for each drug and the cost at each pharmacy. Since IHS or tribal clinics won't actually charge for the prescription, the numbers really don't matter very much. But what's important is that the pharmacies in the network for this particular drug plan, and the plan covers the medication. If you have those two things, it's a pretty good choice for the tribal member. So in this case, you can see by the green arrow that Tohatchi Health Center is a standard in-network pharmacy, so the plan will pay Tohatchi for every prescription it fills with Medicare covered by that drug plan's list of covered drugs or formulas. And there's a similar chart for each of the three pharmacies that we selected the price. Now, scrolling just a little further down on that same page, you can see there's a list for the coverage tier for each drug from this particular insurance company. If a drug isn't covered at all, it will say so on this list. And that means that the IHS or tribal pharmacy will not be reimbursed for the medication. You can also tell just by the fact that there was a discounted price on the chart that we just saw that the drug is covered by the insurance plan, because you don't get a discount unless it's covered. Now, as Amanda mentioned, in some cases, tribal members may need to use outside pharmacy. Maybe they get a medication that isn't in stock at the IHS facility, or maybe they're just too far away for a quick refill that they need. So when choosing a Medicare drug plan, you can select local outside pharmacies to price as well, and it's really wise to choose a Medicare drug plan that includes at least one local pharmacy near the tribal member's home in the network. So just to give you an example, I priced a chain pharmacy near the Navajo Nation in Gallup, New Mexico. This is included in the drug plan we used in our example. Stevie would see a very low cost for his medications, although in most cases, he has to pay those costs out of pocket. The important thing to remember is to ensure that any Medicare drug plan that you choose to enroll in includes outside pharmacies that are convenient to you in addition to IHS options. And by the way, if you have full LIS or Medicaid that are not enrolled in a Medicare drug plan, the first time you go to an outside pharmacy, they will fill your prescription at LIS rates, which are $3.60 for a 30-day supply of generics, for $8.95 for a brand name drug. And then they'll enroll you randomly in a zero premium Medicare drug plan. That'll help you right at that time, but that may not be the best choice of plan for your situation. It's better for you to choose your own plan using the Medicare Plan Finder, preferably in advance, so that the IHS facility gets reimbursed every time you fill a prescription and you're ready, you have the need for that outside pharmacy. So that's all I have. I'm going to turn it back to Bonnie.
Thank you, Ken. This was a lot of detailed information, and we do apologize for technical difficulties here. So I want to thank both Ken and Amanda for this wonderful presentation. I would like to open up the call for any questions and comments. Operator, could you ask if there are any questions or comments from the audience?
As a reminder, to ask a question, you will need to press star 1 on your telephone. To withdraw your question, press the pound key. Please stand by while we compile the Q&A roster. And again, that's star 1 in order to ask a question. And there are no questions at this time.
Okay. Well, again, I want to thank you, Amanda and Ken, for your participation on today's call, and thank you for the participants for listening in. And again, we apologize for any technical difficulties that we had today. And as a reminder, I just wanted to mention to you that Tribal Affairs has established a mailbox for all the participants on the call to submit additional questions or feedback and suggestions for any future topics to be discussed on the calls. The mailbox is tribalaffairs@cms.hhs.gov. And please note, this Friday, November 15th, from 1 to 2:30, there will be a second webinar focusing on Medicare enrollment and payment options for freestanding tribal clinics. And please visit the CMS American Indian Alaska Native Spotlight page to register at http://go.cms.gov/A, Spotlight. Let me repeat that again. http://go.cms.gov/A, and S for Spotlight. And don't forget to check the CMS.gov website for additional information on CMS tribal programs. And that website address is http://go.cms.gov/A, Once more, thank you for your participation on today's call. Enjoy the rest of your day, and this concludes today's call.